Next, I call upon Dr. Parvati Banu.
Good afternoon, everybody. So today I'm going to discuss an out-of-the-box topic completely. I just want to know from the audience, how many of y'all suffer from any neck pain, shoulder pain, back pain after prolonged surgery or back-to-back surgeries? Do you all experience some discomfort, pain, tingling, numbness? So I hope there are some takeaway points after this lecture. So it is an out-of-the-box topic, hardly discussed in our conferences, but very important for us surgeons to avoid the risk of MSD, not Mahendra Singh Dhoni, but musculoskeletal disorders. So what is ergonomics? Ergonomics is derived from two Greek words, ergos, which means work, nomos, which means laws. Simply put, it's laws at work, and the main aim is to optimize interaction between the worker, the equipment, the task, and the environment. So we want to create an awareness about ergonomics to establish a safer environment at work and therefore reduce the percentage of WRMD, which is work-related musculoskeletal disorders. Ergonomics becomes important because of the risk of WRMD leading to cervical pain, cervical spondylosis, vestibulo-basilar insufficiency, absenteeism, burnout, lower job satisfaction. It can even impact the surgeon's performance and in severe cases may lead to disability. Surgery is hurting surgeons. Aptly said by Dr. Roland Campbell, a rhinologist and a head neck surgeon from Sydney. Nearly 70 to 80% of us suffer from some degree of work-related musculoskeletal disorders, and this could be because of lack of awareness of ergonomics during our training program. Otolaryngology is considered to be a surgical field with a very high degree of ergonomic risk, probably because of the equipment which we are using, like the headlights, the endoscopes. We are operating in a very restricted anatomical area. There is repetitive fine motor movements like curetting, drilling, and an ergonomically unfavorable prolonged stature. Now this is a picture which we are very familiar with as surgeons, but this does pose an ergonomic risk because the neck is bent where the craniovertebral angle, which is the angle between the tragus and C7, is more than 30 degrees. The upper back is bent, there is no support to the lower back, the forearms are not supported. So this does pose an ergonomic risk. So the prevalence of MSD is maximum in the neck region, followed by the lower back, the shoulders, the upper back, and even in the wrist. So broadly, if we divide our surgical fields, it is the otology, the nose surgeries, and the head neck surgeries. In ear surgeries, because of the equipment which we are using, like the microscope, headlights, loops, endoscopes, we are working in a very narrow space. There's awkward positioning of our forearms and our wrists, prolonged static posture, repetitive movements like curetting, and prolonged drilling, which leads to numbness in upper extremities. Earlier on, it was only the microscope which we were using for otology, but right now with endoscopes and exoscopes, the entire scenario has changed. Only microscopic usage has shown to be much more at a higher risk ergonomically compared to exoscopic ear surgery, simply because the CV angle is found to be more than 30 degrees most of the times. So if we compare the figure A with figure B, which would you say that is much more ergonomically favorable, figure A or figure B? A. Because it is following most of the ergonomic principles of having an erect neck, spine, the back is supported, the feet are placed flat, and the forearms are supported on the patient's body. So most of us are using monitors, so it has to be placed at least 12 inches from our eye level. That is, the upper level of the monitor should be at our eye level at a distance of 12 inches. Again, when we are doing nasal surgeries with using headlights or loops, this is the posture we adopt when we are doing septoplasties, rhinoplasties. This again poses a high ergonomic risk in comparison to this where we are following most of the ergonomic principles. Head neck surgeries, again, because of their prolonged duration and the neck where the CV angle is bent at more than 30 degrees, does pose a problem. It has been shown that for every 1 inch forward tilt of our head, there is an additional 10 to 12 pounds of pressure on our spine. This is probably due to the stretching of our ligaments, which leads to cervical problems. So MSD can lead to complications because of the prolapse of the intervertebral disc. There could be pressure on the nerves. It could lead to cervical spondylosis, in extreme cases vestibulo-basilar insufficiency, and abnormal placement of our forearms and wrists does lead to carpal tunnel syndrome. So there is something known as a ruler tool. It's a rapid upper limb assessment tool. It's a validated tool to measure our body posture by observing our intraoperative photographs. So it's a screening tool to assess the risk of MSD, and we observe the muscular effort during repetitive movements. There is a scoring method to indicate the urgency for any intervention. So in ruler score, the upper arm score is 1 to 6, the lower arm is 1 to 3, the neck score is 1 to 6, the trunk is 1 to 6, and the wrist is 1 to 4. So if the total score is 1 to 2, then it's a negligible risk and no action is required. But if it's 6 plus, then some change has to be implemented in our working environment. So basically we are taking, for the ruler tool, we are taking intraoperative photographs of the operating surgeons. We're using protractors. We are trying to measure the degree of deviation from the neutral position regarding the neck, the upper back, the forearms, the arms, and even the wrist. And based on the degree of deviation from the neutral position, there is scoring system done. So this is for the different parts which we are scoring. And so what are the corrective measures or take-home message? Basically, we have to follow ergonomic principles. So we have to maintain a neutral spinal positioning. The CV angle should be less than 30 degrees. The upper spine should be straight. If you are sitting and operating, the chair should be ergonomically favorable for our lower back. The angle between our thigh and torso should be at least 100 degrees. The feet have to be placed flat on the ground. Having a foot pad close to our feet avoids unnecessary stretching. Height of the OT table should be adjusted so that the CV angle is maintained to be less than 30 degrees with proper positioning of the lights between the operating surgeon and the assistant. Monitor has to be at least 12 inches from the operating surgeon, where the upper level of the monitor should be at our eye level. Using powered instruments like a coablator, debrider, drills reduces the operative time, and micro breaks and stretching is essential, especially in prolonged surgeries, because this leads to increased flexibility of the muscles by increasing circulation and thereby decreasing the muscle tension and stress. So simple exercises which all of us can follow are the neck exercises, the shoulder exercises, the stretching of the arms, and this will help to reduce the risk of MSDs. Thank you.
I request Dr. Praful Sakre to hand out the certificate to Dr. Parvati Banu. Next talk, Dr. Amrapali Pawar.